Everyone, will get going. Um, I wanted to speak this morning a little bit about neonatal neurology. We don't do too much during grand rounds, and I don't think I've done this in the last couple of years, certainly for our grand rounds here. I did present a number of years ago at the PCH's grand rounds, general peds grand rounds. So I wanted to talk a little bit about current understandings in terms of PVL, or periventricular leukomalacia, and what it is about the preterm brain that predisposes these children to it. So I don't have any conflicts of interest or disclosures as far as today's talk. The objectives have been included, but basically look at some of the mechanisms underlying why there's this predilection for white matter vulnerability in the preterm brain to HIE, and then also talk about some of the vascular unique aspects about prematurity before the brain fully matures, and then finally look at the role of the pre-oligodendrocytes, which are the predominant cell type in the brain at this time. And I just wanted to start with an acknowledgement to two of the mentors that I was extremely fortunate to have worked with in the past, and really developed a love for me in neonatal neurology in particular. On the left side is Victor Dubowitz. Most people will know him perhaps a little more from the field of neuromuscular disease, and I spent some wonderful time in London working with him. His wife, Lily Dubowitz, was also a very renowned neonatal neurologist. But going on rounds with them was quite phenomenal at Hammersmith Hospital, the two of them. And people are still familiar with the Dubowitz and Dubowitz score named after them. And on the right side is probably the doyen of modern day neonatal neurology, Joe Volpe from Boston Children's, who's written the sort of definitive textbook, and probably most of the research around this area has come either directly from him or through his proteges over the years. So if we look at prematurity, there's still about 60,000 infants every year born in the US. And although technically prematurity is regarded as less than 37 weeks gestation, in general, when we're talking about the PVL type of picture, we most commonly think about babies under about 1,500 grams, which translates into roughly about 32 to 34 weeks gestation. That's the group that's most vulnerable, and the group in particular that we often see this in is around 28 weeks gestation. The neonatologists have done a remarkable job with survival, and pretty much all of these babies will now survive compared to when I first started doing this work. And what's quite remarkable, actually, and as I'll show you, it hasn't changed very much, is that when you look at the survivals, only about 10% will develop cerebral palsy in its strictest sense. There is about a 25 to 50% incidence of neurodevelopmental problems, including some behavioral issues in these children, but true CP is only at about 10%. However, with the improvement in care, we are now seeing the survival of younger and younger gestation and younger weight. And so for those children now born under 1,000 grams, the survival rate's about 70%, which is also truly remarkable. But we do see a slightly higher burden of neurodevelopmental issues, including cerebral palsy in this particular group. But the vast majority of my talk today is going to talk about that group, that's sort of the sweet mark around 28 weeks or so. This was an interesting study from a few years ago from Australia, but they have a really wonderful database around cerebral palsy, and they were looking at the motor impairments in particular in preterm children over about a 15-year period. And if you look at the top part of the children born prematurely or with extreme low birth weights, you can see that the change in percentage of CP diagnosis over this 15 years really did not change very much at all. What did change, however, was the non-motor manifestations of cerebral palsy with a significant p-value that almost doubled from the early 1900s into the mid-2000s. But the instance of CP itself remained fairly constant. So we're all familiar with the basic pathophysiology for premature injury. The two broad categories are periventricular leukomalacia, or PVL, which is what I'm going to address today. And then the other really big group or pathology that this group of infants get is IVH, or intraventricular hemorrhage, but I'm not going to really talk at all about that today. So I love using this quote from Charcot, the famous French neurologist, who basically stated that disease is from old and nothing about it has changed. It is we who change as we learn to recognize what was formerly imperceptible. And there's perhaps nothing more true about this statement than PVL. Although we often think about things in modern terms and the discoveries in modern terms, when you actually go back in the literature, you realize that much of this was really described centuries ago. And one of the oldest areas that people did work in the mid-1800s was, in fact, cerebral palsy of children, although it wasn't noted that until the end of the 18th century, end of the 19th century. So this young man really is the first that changed the world regarding CP and the knowledge of CP. And this is John Little, an orthopedic surgeon. And I enjoy including a little bit of the historic aspects to try and understand what we know today, because again, a lot of the information we have today was really identified a long time ago. They just didn't have the tools necessarily at that time to make the diagnosis. And there are two really, I think, fundamental parts to the history of PVL. And the first starts with John Little, who was an orthopedic surgeon. He himself had polio, and he had undergone as a child subcutaneous tenotomy, which gave him his interest in orthopedics, in orthopedic surgery. And he was really the first person to group a cohort of children and describe cerebral palsy as a clinical entity, although it wasn't named cerebral palsy at that time. And he had two really pretty famous monographs now. The first of these was in 1843, in what he termed the nature and treatment of the deformities of the human frame, essentially referring to CP. And in that paper, he really emphasized the aspect of prematurity, that the vast majority of the children he was seeing at that time were born prematurely, and he talked about asphyxia and the need to be resuscitated. This latter part is a little bit what has led to even modern day litigation about that this is obstetric mishap, which we now know is not really true, and especially not true as far as the premature brain. And he noted two factors of etiological importance. The first was the poor maternal health, and certainly infection at that time was a really big deal, and that is very true even today. But the second was he noted that with prematurity, there was an inability of the infant to cope with the environmental stress, and that has really proved to be very pertinent. The second lecture he gave in London was in 1853, again on the nature and treatment of the deformities of the human frame. And what he noted was that the spasticity in these children was not always symmetrical, and in particular made the point that the legs tended to be much more severely affected than the arms. And this we know today is sort of the hallmark of prematurity, which is the so-called spastic diplegic presentation. And he also pointed out that epilepsy was although he said occasional complication, when you read the literature at that time, they really noted it at quite a significant incidence. And so towards the end of the 19th century, after work by Freud and others, and having classified cerebral palsy, the entity or the concept of spastic diplegia as a separate new nosological entity was described and really attributed to the early work done by Little. And also, again, the emphasis being on both prematurity and on birth asphyxia. But perhaps the second and more profound change that came was with Betty Banker and LaRoche. And Betty Banker was a famous pathologist, married Maurice Victor, who was also a wonderful pathologist, and ultimately they moved to Cleveland, and there's a lot of legacy there from the work that they did. But this really remarkable paper from 1962 really talked about and named periventricular leukomalacia of infancy as being the sine qua non insult that these premature babies developed as far as the brain insult. The other thing that was really remarkable and got lost for many, many years, and we'll come back to a little later, is they talked about it as being a form of neonatal encephalopathy. So even though the pathology at that time was localized to the white matter, they did talk about it being a more extensive encephalopathy. They also made the point that the actual abnormalities themselves emerged during the neonatal period. That wasn't necessarily a perinatal or prenatal issue. that there was necrosis of tissue in the periventricular region, which is why they named it the PVL. And they really sort of were the first to identify this border zone in vascular supply of the premature brain, which is one of the key concepts in prematurity leading to PVL, and we'll talk about in a little while. But more importantly, they did notice back then a diffuse loss of nerve cells involving the cerebral cortex. And for many, many decades, this aspect of prematurity and PVL got ignored. So if we look at the traditional thoughts around PVL, periventricular leukomalacia, as already mentioned, it's the classic lesion in a baby under 34 weeks of age, typically around 28 weeks mark. But the weight seems to be the most critical incident, and it's about 1,500 grams. And the neurodevelopmental problems occur in about 25 to 50% of these children. It tends to involve asymmetric, non-hemorrhagic, and ischemic white matter injury. This is distinct from IVH, which more often is unilateral, certainly asymmetric, and is a hemorrhagic venous infarct, whereas this is a small arterial ischemic insult to the brain. And not only do you see it in the premature infants, but you also see it in sick term infants. So you can get, although we typically teach PVL as being a premature lesion, in term babies that are really very, very sick and hemodynamically compromised, you may actually see PVL develop. So the two principal components of TVL, one is a loss of all the cellular elements, the so-called leukomalacia, and this is the cystic element of PVL, which fortunately these days is really much less significant than certainly 20, 30 years ago, where the cystic PVL was really quite a prominent feature. And this probably has to do with changes in the way we manage these babies, or the neonatologists manage these babies after birth. The more common lesion, though, that we see is this diffuse white matter scarring or gliosis in the periventricular zone. And it's really occurring at a time where the major cell type in the white matter is the pre-oligodendrocytes. And as I'll allude to later, these pre-oligodendrocytes are exquisitely sensitive to hypoxemia and become very, very resistant to hypoxemia once they mature into full adult oligodendrocytes. So if we look at the neuropathology, this is coronal section through the brain. We have the lateral ventricles, cavum septum pellucidum, the corpus callosum here. What we see within the white matter is this diffuse pale areas on the H&E stain, particularly around the frontal horns. And this is the diffuse form of periventricular leukomalacia. But occasionally you'll also see these cystic areas, which may be isolated little cysts. They may be macrocysts, or they may actually be coalescent cysts. And this is more of a focal, almost a stroke-like a picture where you get a loss of all the neuronal elements. And this is important because with diffuse PVL, you have really the involvement of these pre-oligodendrocytes, and this is what gives rise to a lot of the complications that we now know as part of PVL. It's this macrocystic cystic lesions, particularly around the frontal horn, that gives rise to the so-called spastic diplegic form of prematurity. And the focal areas can either be microcystic, these tiny little punctate areas, or more commonly, these larger macrocystic areas. And this is, again, a pathological specimen just showing how severe it can be, where you get this sort of cystic breakdown of the white matter. But as you can see, you also get quite significant gliosis and volume loss of the white matter, with seemingly complete sparing of the surrounding cortex. And just more magnified view showing complete destruction of that white matter due to the so-called macrocystic PVL, which, again, just to highlight, is fortunately a very rare complication these days of PVL. When diagnosing PVL, one of the biggest mistakes I think that we still make is we rely on the ultrasound for the diagnosis in these babies. And ultrasound is really not very sensitive to the diffuse form of PVL. It's very, very good because of contrast, the gray-white contrast scale, excuse me, of the focal PVL, the cystic PVL. but you can often miss the more diffuse PVL. And really, you want the MRI, and in particular, diffusion-weighted imaging, to be able to help you with that. So this is a ultrasonic coronal view of the ventricles, the frontal horns up here. And what you see are these macrocystic areas within the white matter, making cystic PVL very, very easy to see on ultrasound. However, when we look at the MRI, the T2 images, because the neonatal brain, and in particular the preterm brain, is so undermyelinated, it undergoes tremendous myelination during the first 2 years. The water content is exceedingly high in the neonatal brain. And so when you try and look at these T2 imaging, it can be really difficult sometimes to really notice any abnormality on it. However, if you do a DWI, you can see the extent here in this particular baby of these more diffuse PVL that is going to emerge later on. And later on with ultrasounds, it may become more apparent, but early on, it can be really very difficult to see. And this is just an example looking at a baby at five days of age and then 10 weeks later. And in the in slides A and C, you're looking at the T2 weighted images. And although you get the impression there's something going on in the white matter here, it's really a little bit difficult to see, although there has been a little bit of cystic breakdown in the white matter by 10 weeks. But again, if you look at 5 days using the DWI imaging, you can see how sensitive it is to the PVL that will later become apparent. So again, appropriate imaging in the newborn is important. And all too often, I see babies discharged from the NICU with a ultrasound before they leave saying, they don't recognize cystic PVL, saying there's no obvious PVL and the baby's going to be fine. And, sure enough, we'll see them a few months later in clinic and they have signs of classic spastic diplegia. Again, just showing a ultrasound in the same baby. This ultrasound's at 7 days of age. And I think you'd be pretty hard pressed to find or to comment on maybe PVL in this frontal region here. But looking at the DWI, it becomes very, very easy to see the deficit, the defect of what's going to emerge as PVL for this baby. So if we look at the classic MRI findings for PVL, there are really 3 components to it. The first is the scarring of the white matter, or the gliosis. It occurs classically in 3 areas. The first is in the frontal, around the frontal horns, and that's important for the emergence of the spastic diplegia. The second area is the trigone region towards the back of the occipital horn. And the trigone region is really carrying the auditory and optic radiations and is responsible for a lot of the higher function, visuospatial, and some of the auditory processing difficulties these babies have. And then finally, you get significant loss of the white matter. So you see the ventricles and the cortex almost abutting one another. Now, if the PVL is bad enough, the entire region of the periventricular zone is going to be gliotic and scarred. One caveat I will mention is that you only start to see enough mature oligodendrocytes to end up getting this gliosis and the microglial cells at around 28 weeks gestation. So when you look at PVL in a baby born at about 24-ish weeks or thereabout, you see the classic findings of PVL. It's just you have compensatory dilatation of the ventricles. You don't see a whole lot of gliosis in the white matter. And that's just because of the gestation at which it occurred. And you can see the obvious difference here. This is obviously a slightly older child with full myelination. But again, this is what it should look like. And you get a loss of the central white matter. So when you look at the corpus callosum, it is complete, but it's very, very thin and very, very narrow. And so ultimately what you see in these scans is you get the gliosis around the periventricular zone, the trigone, the frontal region. You get colpocephaly or dilatation of the occipital horn with loss of white matter and the cortex almost abutting the ventricles. And you get this thinning of the central white matter or the corpus callosum. And this is sort of the more traditional classic findings of PVL. So what is the clinical correlates to PVL? Well, we know that the cystic PVL is really what's associated with the spastic diplegia, and in particular, because it occurs around the frontal horns, which is where the descending leg fibers are. The diffuse PVL is really what's responsible for that 25 to 50% incidence of other neurodevelopmental problems, cognitive and behavioral, as well as learning, but not the actual CP component. And this, everyone's familiar with the so-called homunculus representation, and we know that the leg fibers descend. This should be more medially. And so when you get cystic PBL around these frontal horns, it's really going to be taking selectively the leg fibers. Now, often with PBL, you will see some involvement of the upper extremities, but proportionately, the legs are significantly worse than the upper extremity. And then the end result of it is this classic picture of a child with a scissoring gait, a spastic diplegic gait, but really good upper body and arm function to allow them to ambulate, usually with assistance of quad canes or other reverse walkers or something, or some type of support. So turning then to the pathogenesis of PBL, there are really three components that are unique to the premature baby that results in PBL. And we're going to talk about each of these very briefly. The first is the vascular anatomy that gives rise to a watershed zone that is actually in the deep white matter here rather than on the cortex, as you see in the mature vascular anatomy cases of an older child or term neonate. The second is you end up with what's referred to as a pressure passive cerebral circulation, where you lose the ability to auto-regulate. And so blood pressure control becomes a key component. And postnatally, we are not really as good as a placenta and able to regulate and moderate blood pressures in these premies. And then finally, it's occurring at a time where the predominant cell type are these pre-oligodendrocytes. So if we look first at the anatomic factors, so if we're all familiar with the term baby, the child, where the classic periventricular zones are between your anterior circulation and your middle cerebral circulation, and your posterior cerebral artery circulation and middle cerebral artery circulation in the so-called watershed pattern. And then you also have the internal border zone, which is between your MC and your lenticular striates. So you get this very classic so-called parasagittal watershed zone in term babies or children that undergo hypoxemia, but more particularly undergo hypovolemia or drop of blood pressure. Now, in the preterm brain, the vascular anatomy is set up a little differently. Until about 32 to 34 weeks, the orientation of the vessels are a little different. You have from the surface these short and long penetrators that are coming down towards the deep regions of the white matter around the periventricular region. And at the same time, you have these ascending basal penetrators or perforators that are coming up, so that you end up with a watershed zone that is in the deep white matter rather than on the cortex, as I've just alluded to. And as a result of this, you end up with a watershed zone in the region of the deep white matter. And this is the area that we classically see PBL. And this was work done a number of years ago. And still some of the best papers for PBL still goes back decades, which is why you'll see a lot of these older papers referenced. And this is out of Papay and Wigglesworth, wonderful pathology book. This is just a half of a brain here, the sylvian fissure, the cortex in the dark red. This is the ventricle over here, just to orient you. And here you see these basal penetrators coming up from the into the basal ganglia, thalamic region, and then you see these long and short perforators coming down from the cortical surface. And what you see here along here's your ventricle, along the frontal horn of your ventricle is this hyperperfused area, so that if there's sudden drop in blood pressure for any reason that is common in these newborn babies, this is the zone of watershed injury that you're going to see. The second unique feature is the pressure passive circulation. And as we all know, that the perfusion pressure to the brain relies on your mean arterial pressure driving blood in, less the difference of your intracranial pressure sort of trying to force blood out. And it's the difference of these two which actually gives you your cerebral perfusion pressure. Now, in a child, we know that there's an area, a range of blood pressures or mean arterial pressures in which the brain can auto-regulate through chemoreceptors, vasoreceptors, and you can keep the cerebral blood flow at a fairly constant level despite changes or fluctuations in blood pressure. The same is true for the neonate. The only difference is this level of autoregulation is much, much more tightly controlled, and it's a much, much narrower range. So the ability to tolerate difference is harder. However, when you get to a premature baby, or when you get to a sick term baby, they actually lose any ability to autoregulate at all. And you now end up in this terrible situation of what's known as a pressure passive circulation, meaning that for every change in blood pressure, up or down, you see an immediate change in the cerebral blood flow and the pressures that the brain, the neurons, and the oligodendrocytes are receiving. So at the top end here, as the pressures go up, you run the risk of IVH and hemorrhage. And as the pressures come down, you run the risk of ischemia and so-called PVL. And this was work done by Alan Rosenberg. That was, again, a number of decades ago out of Volpe's lab. And they looked initially at asphyxiated lambs. These were term lambs. But again, if you look at the control, you could see there was a level that these lambs were able to autoregulate very, very easily. Once they became asphyxiated, you see they became pressure passive. And while this is true for the term equivalent of the neonate, as shown on the right panel, where they lose the ability to autoregulate, it is also true of the premature baby that is sick. And another remarkable study done by Perlman that also used to work quite a bit with Volpe and Rosenberg in the late 70s, early 80s. And this led to one of the most significant changes in the way that we sort of manage the neonates these days, was the response of the neonate to pain. And I think we heard a week or two ago a pain lecture about how neonates do experience pain. It's just often under-recognized. So what we have on the left side of the graph is arterial blood pressure, and then they were recording cerebral blood flow velocity at the same time. And with arterial blood flow, you have the really nice sinusoidal systolic diastolic peaks, and you can see that that's reflected in the brain. And we know from some of the cardiac studies that this sort of peak and valley, the systolic diastolic sort of swing, is really important for the health, particularly of neurons in the term babies, but it's also very important for the pre-oligodendrocytes. All they did here was simply monitoring the children while they were getting deep suctioning. And this was, again, in the early 80s when the deep suctioning was done without any sedation. And this was really very distressing and uncomfortable for the babies, for the neonates. And what you see is this very erratic, these high peaks, these very low zones at the bottom, the valleys. But it was really a very irregular pattern. And sure enough, the same pattern was reflected in the brain. And every time that it peaked, you run the risk of hemorrhage. And every time it really bottomed out, you run the risk of hypotension and PVL. So the third component of this that became really important was the timing at which this started to occur. So if you look at a pre-oligodendrocyte, it has very, very few articulations and ability to communicate with the other cells. And what you see is that at about 28 weeks, the vast majority of cells in the white matter still comprise the pre-oligodendrocytes. And it's at this time, between about 28 and 32 weeks, that they start to mature from pre-oligodendrocytes into the mature oligodendrocytes. Once they are mature, they become very resistant to hypoxia, whereas the pre-oligodendrocytes are exquisitely sensitive. Now, this was incredible work done by Stephen Back in the early 2000s, and Stephen's now in Oregon. But the work that he did was, again, just to confirm and show that at around this time of prematurity, 24, 28-week range, the predominant cell population in the white matter are these oligo precursor cells, and that the sort of switch over to them becoming mature myelinated cells occurs at around 35 weeks. And again, using a variety of different stains, we can sort of differentiate that. So initially, we have these pre-oligo progenitor cells and the pre-oligodendrocytes that migrate, proliferate into the white matter, and then they start to develop the synapses, and then you get the immature and finally the mature oligodendrocytes with multiple synapses. But it's this population that's really abundant at the 24 to 28-week mark. And this is just, again, showing a lot of these pre-oligodendrocytes, it's 28 weeks, but not really communicating well with the sort of neighbor pre-oligodendrocytes. The synaptogenesis is still very, very immature. So why is this important? Well, again, work that was done back then showed the effect of hypoxemia, which was represented in these studies by introducing free radicals. So what these graphs show is percentage survival of cells in a petri dish. If you look at mature oligodendrocytes first, once you put in a free radical into the culture medium, you could see that the survival between the mature oligodendrocytes that either had free radical added or those that did not have any free radical added was essentially unchanged, basically telling us that free radical hypoxemia didn't have much of an effect on these mature oligodendrocytes. However, with the pre-oligodendrocytes, when free radicals was introduced into the medium, you can see that the loss of cells in the survival was reduced significantly. Sorry, the wrong way around. When there was no free radical, the negative means no free radical. Once a free radical was introduced, survival rates were only at about 20%, whereas in the mature oligodendrocytes, with or without free radical, there was really no difference. And so a lot of the early work we're looking at scavengers for free radicals, and vitamin E at one stage was very popular. And what it showed that you could add vitamin E at 12 hours after the insult, 15 hours after the insult, and in this case, birth of prematurity, and you saw an incredible increase in the survival. So once you had a free radical scavenger added into it, you could see even as much as 15 hours, there was quite good survival of these oligodendrocytes. However, if no free radical scavenger was added, you had only about a 15–20% survival. And this led to, in the early, sort of the early 2000s, it was, people were using these really incredibly high dose vitamin E. There was a time that people were using Topamax topiramate as a free radical scavenger because of the AMPA receptors. And as always, what goes from in vitro into in vivo really had very little to no effect in real life. And in fact, we learned that these high doses of vitamin E actually made the retinopathy of prematurity significantly worse, which resulting in significantly impaired vision for these babies. And that's why these sort of super high doses of vitamin E are not used. And I'm not sure vitamin E is given anymore to the premature babies. They just showed it again. So edebenone is just a synthetic form of, is a natural form of coenzyme Q10, which again works in the mitochondrial chain for complex 1,2 shuttling enzymes to complex 3. And if you gave vitamin E or you gave edebenone into a culture medium where you introduce free radicals, the control group that did not get any salvage had again the 15–20% survival. Whereas if you use either edebenone or vitamin E, the survival was really very, very good at 92–95%. Once again, though, the reality of this was that the use of edebenone in the premature babies had absolutely no effect. It was also used for HIE, by the way. So this led to an evolving view of PVL over time. And the question became, we could really explain very well based on the white matter location of these lesions, just on an anatomic basis, why they got the spastic diplegia. But the question started to be asked, well, why do we see such a high percentage of cognitive, behavioral, and other neurodevelopmental deficits in these premature babies that were not motor, were not CP related? Again, the concept at the time was it was this premature lesion, which was symmetric, ischemic, and was a white matter injury. And this led to a complete change in thinking in the early 2000s. And there was the realization at that point through a number of studies, which I'll go through quite quickly, showing proof of concept, that it was in fact not just the oligodendrocytes, but you'd have a dying back of the axons. So this was almost reverse necrosis and then infecting the neurons themselves. So that in fact, PVL was not just purely a white matter injury, but actually involved the neuronal axonal axis as well, getting back to Betty Banker, who sort of alluded to this in the early 1960s and showed pathologically that the cortex was involved. Now, the reason that this was missed or neglected for so long is when we look at these children with PVL, it's very easy to see the loss of white matter. It's very easy to see the colpocephaly and nucleosis. But remember, the cortex in the babies, in the child even, and even as an adult, is only 5 to 6 millimeters in size. So to see a dropout of neurons is going to be very, very difficult if you have a dying back of the axons. And the MRIs are sort of 2D imaging of the brain. So you really can't get a volumetric of what the entire volume of the cortex involves. So this was incredible work by Terry Inder, which was a fellow still in Petra Huppi, who is a wonderful Swiss neuroradiologist, again, working in the Volpe lab. This was really one of the most powerful papers to come out in the late 1990s, which really showed that if you look at premature infants, there was actually a significant reduction in the cortical gray matter. So if you took children born at term without PBL, obviously, the volume of gray matter was roughly 218 milliliters. If you took babies that were premature but did not have any evidence of PBL, there was a reduction in gray matter, but really wasn't that significant. But then if you looked at the volumetrics, if you looked at the amount of gray matter in children born prematurely with PBL, there was really a striking, significant difference between the volume of gray matter on average from 2018 down to 157 cubic milliliters. So this was the first time in real time that PBL was shown to be impaired or to impair cortical development, even though, as I say, in retrospect, this honor probably should go back to Betty Banker. And this is just a different way that they illustrated this a few years later. So if you took premature infants that did not have any evidence of PBL or white matter injury, quite a large number of them, you can see that the average in terms of the gray matter was around the 200 mark, and that if you looked at the ventricular size or the CSF volume, it was just below 40 mLs. On the other hand, when you looked at these premature infants that had PBL, the total gray matter was significantly reduced, as I just talked about. And then obviously, because you have a reduction in the white matter and in the gray matter, you've got to have compensatory dilatation of the ventricle. And so it was shown that the ventricular fluid volume, or the ventricular size, if you like, was increased. So again, just proof of principle. The second really large support for this came in the mid-2000s from Hannah Kinney, a wonderful neuropathologist, also out of Boston Children's. And what Hannah showed was that when you look at PBL, in addition to the classic white matter injury, you do get significant neuronal loss as well. So you get significant gray matter injury, again, just really confirming what had been known decades before, and that it's occurring at sites that are really important for cognition, memory, and learning, including areas like thalamus, basal ganglia, hippocampus, cerebellum. And then again, subsequent work by Hannah Kinney showed that there was at least a third drop in density layer 5. So this sort of selectively was involving the pyramidal layer 5 neurons in these cases. Again, not a big series, but subsequent work has really confirmed this. And so again, if you look at the areas of brain involvement, although we think about it as white matter by all these little white dots that are, or these little red dots or pinkish dots that are illustrated, there is a significant involvement of gray matter as well. And so when we look at PBL, it's really a more comprehensive disease involving the whole neuronal, axonal, oligodendrocyte axis. So in addition to the white matter injury that we talked about, you also start to get damage to the subplate neurons, to the deep gray structures, the cortex, cerebellum, and including the brainstem. And again, particularly around the inferior olive was one of the areas most significantly hit. And there's been a lot of work over the years that has really confirmed this work. So these days we talk more about encephalopathy or prematurity, which is kind of going back to the Betty Banker paper. And so rather than talking just about PBL or prematurity, we sort of more correctly now talk about encephalopathy or prematurity, because we do know that it really involves not just the white matter of the brain, but also the gray matter, both deep gray as well as cortical gray matter involvement. And then there's been some really interesting work in the last decade to show, the concept was that, you had full brain migration by the end of the second trimester, and then third trimester was just growth of the brain, the growth of the white matter, the cortex taking place. But really, some really interesting work from Perides and Morton that came out showed that even by the time of birth and for several months after birth, there's still ongoing neuronal migration. And this may be an area of importance, not just in prematurity, but also in the congenital heart kids who show a very, very similar neurocognitive profile to the premature babies. And the reason for it is though the congenital heart children are actually born at term with a normal gestational age, the development of the congenital heart brain because of fetal prenatal factors is actually that of about a 34-week-old infant. And it's thought that it's these post-delivery, post-birth neuronal migration that is really important for some of the more significant kinds of problems that we see both in PVL and in these children with congenital heart disease that have a very similar profile. So, the subventricular zone is the sort of the cradle, the bed, the niche of where the neural stem cells and progenitor cells sort of migrate from, and they go up along these radial glial lines to the cortex, as we all know, get sort of laid down from layer 6 to layer 1. And then there's a debate as to whether the actual radial glial cells persist as the attached axon, whether they die off and then the neuron actually generates a new axon. But regardless, we now also know that in addition to these descending axonal fibers, there's a lot of interneuronal communication between the two neurons. And these so-called interneurons are really what develops around birth and then the early postnatal phase. And these interneurons have very, very high, when they're present, have cortical inhibitory inhibition. And so it's thought now that damage in these periventricular, the subplate zones, to this population of cells that are still there, that are undergoing migration around term in the first few months of life, is also a significant reason why we see some of the classic problems that we see from prematurity. And this includes a lot of the executive dysfunction because it's in the forebrain region. So things like ADHD, things like processing kind of problems, the more complex kind of issues to do with developmental problems in the premature babies. It's an important structure that's still present. A slightly complex picture, but what we have on the right here, this is a coronal section. This is a sagittal section here of the ventricle, the frontal lobe. And then this is sort of a, again, almost a lateral coronal section. But the important thing to realize is these interneurons start to migrate out as an arc, and they're going to go through two streams. There's a medial migratory stream to the forebrain, and there's also this smaller rostral migratory stream. But it's this area that we know is hit by PVL. And so it's thought that these migrating neurons, which are going to become interneurons, are what gets injured and what gets damaged. And it's a result of these interneurons that give rise to a significant portion of what we now call the encephalopathy of prematurity, of the higher executive cortical functions that are impaired in PVL in about 25 to 50% of babies born under 1,500 grams, under 34 weeks gestation. So I've gone through this a little quickly, but hopefully it'll give a little bit of time for questions. But basically, if we look at PVL, it's still the typical lesion of the premature infant. It is a symmetric white matter injury for the most part, and it's due to these three unique components that we see in the premature brain. The first is this vascular anatomy, which gives rise to the watershed zone being in the deep white matter rather than in the parasagittal cortical region because of these penetrators, both from the cortex and these basal penetrators coming up through the deep greater basal ganglia region. The second is in premature babies, term sick babies, the pressure passive circulation is sort of the default of what's occurring in these brains. And so blood pressure control becomes absolutely critical. And we know that the fluctuation of blood pressure post-delivery in these premature infants is a really significant problem. and management has changed quite considerably. And all of this is acting on a population of cells made up of pre-oligodendrocytes, which, as I showed earlier, are exquisitely sensitive to hypoxemia. Once they mature and become mature oligodendrocytes, it's actually the neurons that become much more sensitive. And that's why when we look at HIE in a term baby, we see the classic pattern of HIE in a term baby involving cortical injury in pyramidal distributed cells in the deep gray structures in the cerebellum and the CA1 of the temporal lobe. So it's a cortical lesion as it is in an adult. Now, the longer that hypoxia goes on, not only are you going to lose those sort of highly selective areas, but you're going to infect the entire brain. So in a term baby, we talk about selective neuronal necrosis, and there's certain areas that are more vulnerable, certain neurons that are more vulnerable, whereas in the premature brain, it's the oligodendrocytes that are much more sensitive and more vulnerable. And on top of this, we've now gone back 40, 50 years to realize that actually it's the cortical gray matter that is responsible for a significant amount of this injury. It's probably the result of both dying back of the axon because of the pre-oligodendrocyte injury. You don't get that axonal formation, therefore you get damage to the cerebral cortex. Very, very hard to see on 2D imaging. You really need advanced neuroimaging to be able to really appreciate that. And then finally, what's become a little more apparent in the last decade or so are the so-called late migrating interneurons that are very important. And so when we think about PBL and we think about prematurity now, we need to remember that it's really more than just a white matter injury. So I will stop there. I went through that just a little quickly, but see if there's anything in the chat. Happy to take any questions.
Neil, this is Michael Kruer.
Yeah.
Wonderful talk as usual. Had a question for you. It's interesting to see how concepts have evolved over time, and as you were mentioning that the focus has shifted over time to pre-oligos and then back to neurons. What about the spinal cord? Is there thought to be much of a role for spinal cord related injury in PBL and some of these processes?
Yeah, so that's a great question. There's nothing, I haven't looked more recently, to be 100% honest, but there wasn't anything in the literature that has really focused a whole lot on that. You do get, sort of thinning of, so sometimes you'll see the brain stem is a little thinner because of the descending fibers, the general loss of the pyramidal tracts, the thinning of the pyramidal tracts. And so sometimes the spinal cords have been a little bit narrower, a little bit thinner, like you see in the brain stem. But I'm not aware that the same issue has applied to the development of sort of either the secondary neuron, the secondary axons from the spinal cord from the anterior horns, or that the anterior horns themselves have been affected with PBL. I haven't really seen literature on that. But it's sort of an interesting, it's an interesting thought, yeah. All right, well, I guess if nobody else has any questions, we'll give you back a little bit of your morning. Enjoy.
I think Dr. Hotman has a question.
Oh, okay. Sorry, I apologize. I'm not seeing it. Sorry.
Yeah, hi, can you hear me?
Yeah.
Yeah, Neil, that was a terrific talk for a dilettante like myself who knows next to nothing about PVL. The one thing that struck me, though, is that some of the concepts seem awfully similar to traumatic brain injury, particularly with regards to loss of cerebral autoregulation. And so I sort of wonder out loud, I mean, is that the direction that this field is going? Is it going in the direction of more intensive physiologic manipulations in preterm children? Like, where do we go from here, and then how do we study it methodologically?
Yeah, so I think you're exactly right. Certainly, it's that pressure passive circulation, which is very, very akin to what we see in traumatic brain injury, that we see in it's not birth asphyxia, but HIE, perinatal depression in a term baby. The only real key difference in that scenario, as I mentioned, because of certain certain areas, is that it's affecting the cortex, neuron, selective neuronal necrosis, rather than that deep white. But principally, it's the same concept. It's just which selection of cells that you're talking about and addressing. The change in management since I first started doing this work in neonatal neurology, I remember sort of in the 80s, everything was hands-on. When we saw these premature babies, you had to examine them and you had to go through all sorts of different maneuvers and do things with them to try to get a sense of how they were doing. Nowadays, you walk into the NICU and the whole concept is don't touch, don't talk, and don't see. It's kept in a very quiet, dark environment, as you know. The concept is to really not touch as much as possible because of this fluctuation of blood pressure. It's really, really hard because of this narrow window of autoregulation to try and manage these babies. And so the best thing is to try to avoid fluctuations. And as I alluded to, one of the biggest changes and one of the most successful changes of all became really heavy, deep sedation when they do so-called interventional procedures. And by that, I mean just things like deep suctioning, which we never used to think of as a big deal. But now, procedures of any sort, they're doing with quite significant sedation in these newborns. And it, I think, has been shown to be much more effective. It's certainly effective in controlling that blood pressure. But yes, I mean, obviously supporting volumes and the traditional stuff we would do within a TBI sort of case or an older child case, they do in the NICU. It's just your armamentarium is much, much more limited compared to what we can do, obviously, in an older child. But that's where we have to be very careful with some of our treatments and some of our medications, that we actually don't exacerbate the situation. So seizures, for example, in the premature brain, the whole brain is excitatory. And so the natural state is for an excitatory brain. The GABA receptors only become inhibitory at around 3 months. And so there's at least a theoretical consideration that the use of benzodiazepines, especially in a premature baby, can actually be counterproductive. And there's a very classic midazolam-induced myoclonus that you'll see at the bedside if you do this long enough, where the nurses will push midazolam and these babies go into incredible myoclonus. It's non-epileptic, but it does to start affect the hemodynamic state. So we just have to be very, very cautious in how we treat these babies, the premature babies I'm talking
about. Hey, Neil, fabulous presentation. I was just going to ask before you mentioned it about the occurrence of seizures. Is there a differential impact on long-term neurodevelopmental outcome if you have seizures with a term injury versus a preemie injury, given the selective variability or differential response of depolarization or hyperpolarization with GABA receptors?
Yeah, it's another great question. And I'd probably answer by saying is the truth is we probably don't know the answer to that. We now know in term babies, and even there, quite honestly, it's a little bit controversial in how aggressively you should be treating neonatal seizures. If you look at the work, some of the early work by Mary Johnson around some of the medications, but mostly the work by Greg Holmes decades ago, showing that it's not clear that neonatal seizures, which are often symptomatic, are always detrimental to the baby. I think in a term baby, it's now generally accepted, generally considered that the treatment of those seizures is probably beneficial. The problem with premature babies is defining what a seizure is, and these premature babies can be exceedingly hard. And I would almost suggest that if you showed 10 epileptologists a preterm baby's EEG, you'd probably get 10 different readings on it, because they can be incredibly difficult to interpret just because of the hyperexcitability state. My personal philosophy is if it's a clear-cut seizure pattern, I would probably go ahead and treat it to a moderate degree, but not to a point of where you're going to start dropping blood pressures or leading to other complications on it, because there is really no good evidence in the preterm brain that it really does much as far as long-term outcome. The other thing is, so I'm a lot more tolerant in the premature babies. The other thing that I've learned over time, and I sort of have almost resorted to, is because A, of the difficulty of interpreting these premi-EEGs, and B, because of the fact that, again, applying these electrodes, fixing these electrodes, messing with these kids on a day-to-day basis to try and to get the EEG readings, as best you can, that in itself can be as detrimental as trying to treat the seizures. So I have a very low tolerance of just treating, because again, at least in a preterm infant, there's some evidence, not strong, to suggest something like phenobarbital is actually neuroprotective in these babies. So I would often just have a much lower threshold to empirically treating if on clinical grounds you think these are seizures, not necessarily waiting for an EEG confirmation. And we know from term babies that the electrocortical signature of neonatal seizures, especially the so-called subtle seizures, is the correlation is very poor. And so in particular in the neonatal seizures, eye deviations, versive eye movements have been the strongest correlated with neonatal seizures. The same is probably true, but there's not good evidence yet for that in the preterm baby. So I tend to be a little more just clinically treating when the baby's reached term. You do EEGs, you can see if you still need to be on medication or not. But they're very tough to treat, the preterm babies, when you're worried about seizures. All right, well, thanks everybody. Appreciate you joining this morning. Have a good day and be careful in the heat out there.